titled Naltrexone in New Age Psychiatry, Expanding Boundaries of Clinical Use. To do the honors today, I welcome Dr. Sidharth Sood, who is a super specialist and consultant psychiatrist with a DM in addiction psychiatry from AIMS New Delhi. His core areas of interest is addiction psychiatry, neuromodulation, and psychopharmacology. His philosophy is bridging clinical psychiatry with modern neuroscience. I hand over the session to you, Dr. Siddharth, to please introduce the panelists on board and begin your session. Thank you, sir.
Sir, I'll just start sharing my screen. It seems you cannot start your share while other participant is sharing. So please. Hello, ma'am.
Hi. Hi, Sidharth.
Good evening, madam.
Good evening.
So good evening, everyone, and thanks for joining this webinar. So we'll be talking about naltrexone, right? As the topic says, naltrexone is a drug which expands clinical boundaries. So after this webinar, I'll be confident that you'll not be thinking about naltrexone just in addiction psychiatry. You'll be thinking about naltrexone in psychiatry in every part and maybe some other disorders too. I'll begin by introducing my esteemed panel. We have Dr. Charvi Kalra, she's a senior resident currently at IBHAS, along with Dr. Pratik Rajput, who's a consultant psychiatrist, having done his MD from IBHAS and subsequently did his DNB also. Welcome, Dr. Pratik. Then we are also joined by Dr. Shubhangi. She has done her both MD and DNB, and ma'am was my senior resident while I was doing my JRship at IBHAS. We are also joined by esteemed members like Dr. Udit Panda, sir is MD and DNB, along with fellowship also from the prestigious NIMHANS. Subsequently, Dr. Siddharth Arya, who is currently Associate Professor in PGIMS Rohtak, and his area of expertise is substance use disorder. And lastly, we have Dr. Pal Soni. He's a consultant neuropsychiatrist at Alpha Mind Care. Welcome, everyone, and we'll begin this discussion with So first of all, the topic is naltrexone in New Age Psychiatry. So what I would want you people to think is why we are talking about New Age Psychiatry, which I'll be explaining. So to begin with, let's see a few case scenarios. In each of these cases, I have seen myself during my training at AIMS and DTC during my DM. First of all, 45-year-old male who was a corporate executive presented with severe alcohol use, with history of multiple supervised inpatient withdrawal managements, and interestingly, patient had cue-induced craving, right? He would remain sober for some time, and whenever he had some cues, he would relapse. Then, interestingly, is gambling. So I saw a male around 32-year-old software engineer who came with the history of having gambled a lot of money. Then, moving from addiction to autism spectrum disorder, a 14-year-old man with severe boy with severe ASD, and who was refractory to treatment with typical antipsychotics, and there was a lot of self-harm. Similarly, borderline personality disorder, presenting with recurrent deliberate self-harms. And very interestingly, even for us now in India, earlier we did not talk about eating disorders, but now they have become very important for us also. So binge eating. Now, first of all, why this talk matters, why this New Age Psychiatry? When drugs started coming in market in 1950s. To talk about schizophrenia, we were talking only D2 receptors. By 1890, we started talking about serotonin, and today we are also talking about glutamate. So the idea is, it is no longer about receptors, it is about circuits. And even with naltrexone, we are not thinking about circuits, we are not thinking only about receptors. And this paradigm matters because in our country, addiction burden is rising exponentially. Similar to substance addiction, behavior addictions are also increasing and they are very under-recognized. And there is a lot of gap between the treatment we are giving in a number of cases. So circuit-based interventions offer neurobiological precision and they expand the scope of psychiatry, right? Psychiatry is no longer the mid branch where we just keep on giving drugs. Circuits have made the branch much more clinically relevant also. Just to giving you an example, this is a figure I've taken directly from Stalls, just to mention about what I'm saying again and again, circuits. So if you see, just for example, starting with substance use, initially it is impulsive, then becomes compulsive, as mentioned in Stalls, right? There's a ventral to dorsal shift. Similarly, similar to this spectrum, we can also think about other things like borderline personality, like kleptomania, like ADHD, impulsivity. Then over time, when it shifts to compulsivity, these all we see. So these are all on spectrum, the impulsivity to compulsivity spectrum. We can think more about circuits rather than individual diagnosis. To bring forth my point about naltrexone, it was synthesized as early as 1960s and has currently FDA approval for both opioid dependence as well as alcohol dependence. And just to talk about its properties, first of all, pharmacodynamics. Pharmacodynamics is simply what the drug does to the body. So it's a pure antagonist. Any antagonist will go bind to the receptor and will not have any intrinsic activity. It will be just block. So, and naltrexone also binds to all the opioid receptors and most importantly, mu opioid receptor with the highest binding affinity and lower affinity for other two receptors. Why this becomes very important is that its binding is far more stronger than other opioids like morphine, which or something like smack, which is diacetylmorphine or heroin as we normally say this. And although it's a competitive inhibition, so it can be reversed, but the amount of opioid that would be needed would be too much, which is practically not possible, although theoretically possible. Now, equally importantly is the pharmacokinetic profile, which makes this drug very interesting. First of all, it is a bioavailability around 5 to 40% due to very high fast metabolism. Peak effect in 1 hour. But what you have to remember from here is that although the onset is comparatively 1 hour, half-life you would is 4 hours. Even the active metabolite has a half-life of 13 hours. But the kind of inhibition that comes from this drug that lasts for around 24 hours with 50 mg. It goes and binds to the mu opioid receptors, right? In drug like naltrexone, we need not worry about the shorter half-life or the shorter half-life of active metabolite also. So these are the basic pharmacodynamic and pharmacokinetic properties that it's a mu opioid receptor antagonist. Simply, it will block mu opioid receptors, which will have a lot of downstream effects, which we'll discuss. So it has two indications which are approved. One is alcohol use disorder, one is opioid use disorder. There are multiple guidelines which mention how naltrexone should be given, right? Some guidelines go on to say that we should do acute withdrawal management first in cases of alcohol use disorder and then give naltrexone. While many guidelines also mention that it can be initiated while drinking also. And here the concept of harm reduction, even in alcohol use, comes such that it will reduce the amount of alcohol that will be eventually taken. So when you're thinking about harm reduction in alcohol, this is one of the strategies. But, and very important, but when using in opioid use disorder, patient should not have used any opioid for 7 to 10 days because very strong withdrawal can happen if we give naltrexone. Always ensure that if you are planning to use naltrexone in a patient with history of opioid, make sure the patient is actually abstinent. Always get urine drug screening. History might or might not be reliable. And despite so much things, despite being such an older drug, came out in 1960s and apparently has so many uses, still it is being ignored. Why? A very interesting paper from 2009 mentioned why naltrexone is comparatively ignored. First thing is the perception of limited effectiveness. Then there is a lot of reluctance from patients also. And sometimes there might be constraints in clinical practice. And this might be the reason that it is also being less used by us also as psychiatrists. And this is something which we need to understand. So this is a paradigm shift. We are no longer talking just about receptors. We are talking about circuits. So earlier we believed that we'll give a simple mu opioid receptor blockade and things will happen. Now it has moved on. So there's circuit level modulation such that underlying reward prediction errors and all things which I'll be explaining come. So this is a basic reward circuit. Ventral tegmental area, nucleus accumbens, and downline dopamine releases. And naltrexone, if we can understand directly, works in opioid use disorder by blocking the mu opioid receptors. But in case of alcohol use disorder, it inhibits the GABA interneurons and thereby reduces the pleasure that comes from dopamine. It's an indirect mechanism, but it's still very effective. And most importantly, one point if I want you to take away from this whole webinar is about the liver safety and about this historical fallacy. There was initially a black box warning about this, about its liver effect, which was actually removed in 2013, around 13 years from now, which came from 1980s from some clinical trials in which it was used at 300 mg. And even then it was used for underlying obesity, right? There were some liver issues and then subsequently this black box warning came and that has somehow still there, that is somehow still there in our minds, although it has officially been removed. So what you need to understand is standard 50 milligram that we are using is actually very safe. There is zero severe drug-induced liver injuries reported, although it is contraindicated in cases of decompensated cirrhosis, hepatic cirrhosis, and active viral hepatitis also. But it is not as dangerous to use as we previously thought. And good clinical guidelines for using naltrexone is, first of all, any patient presenting to you where you are planning to use naltrexone for the various indications which we'll discuss, get at baseline AST, ALT, and bilirubin minimum to be done. Actually, we should also get other things like PT, INR, which are good, far better indicators, but at baseline, these should be done. And once started, it should be rechecked at 1 to 3 months. And if the level of transaminase, that ESC, is 3 to 5 times the normal limit at beginning, we should be cautious and possibly avoid it in those cases. But if it is lesser, maybe 1 to 2 times, we can still consider using it, as the benefit of using naltrexone and reducing the amount of alcohol is more than the harm naltrexone will cause to the liver. This is perhaps the most important takeaway I want everybody to take away from this webinar. Moving on, this is just shows the transaminase levels that decreases, and the suggestion of alcohol toxicity far outweighs the risk of naltrexone that might happen. Right. Now to get down to business, where it is used. The indications approved are alcohol use disorder and opioid dependence use in India. And just to mention this study, which I like mentioning always, 2019 survey, which we are still using. The 2026 survey for drug use is ongoing and soon we'll have the data from that also. But that mentioned that for alcohol, we have total users around 16 crore with around 2.9 crore dependent population, and similarly around 28 lakhs in opioid use. So that is very high, and hence we need to know more about this. In alcohol use disorder, this is something which is already approved. So we started having RCTs about its effectiveness as back in 1992, right, which established its mechanism, its efficacy, its effectiveness in alcohol use dependence, alcohol use disorder, and its benefits versus placebo also. This is back in 1992, right? And in 2006, this landmark trial, which everybody should know, came out, which is the alcohol use disorder, the combined study. It talked about naltrexone, it talked about placebo, it talked about acamprosate, it compared them. And this clearly showed the effectiveness and efficacy of naltrexone. And it is highly effective as a standard clinical intervention. And Cochrane analysis has showed the number needed to treat is around 12. And when thinking about alcohol use disorder, when we think about more practical clinical terms like return to heavy drinking, when we think about cue-induced craving, right, we should think about naltrexone because number needed to treat is just 12, which is a comparatively low number, and it is shown to reduce heavy drinking. It is shown to reduce binge drinking also. So it has highest grade of addiction medicine evidence, such that I mean that this evidence comes from Cochrane review, which, as we know, is the highest level of evidence in medicine possible. So the evidence shows that it favors naltrexone in reducing heavy drinking, in reducing relapse rates. So when we talk about naltrexone in alcohol use disorder, the other drug which is approved that comes to our mind is acamprosate, which is in itself a wonderful drug, which we'll be talking maybe more about in times to come. And when we're talking head to head, suppose naltrexone versus acamprosate, multiple studies have come, right? The combined study from 2006 I was just talking about, that was a landmark trial. But just to talk about head to head, naltrexone is superior for heavy drinking reduction. While what I mean here is that if the goal is not complete abstinence, like most of you clinicians who have seen patients for alcohol use disorder, patients don't always agree to be abstinent completely, right? The goal may be to reduce the amount of alcohol. Now, how effective that as a clinical strategy is again debatable. There is evidence for and against it. But to reduce the heavy drinking, naltrexone has superior evidence. While for increasing total abstinence, acamprosate has more evidence. Interestingly, if we combine both of these, there is no additive benefit. Although we might sit and think, let's give everything to the patient, but there is not a lot of benefit. Moving on to opioid use disorder. So naltrexone is a mu receptor blocker. It's a mu receptor antagonist, so it makes total sense to give an antagonist to prevent any other endogenous or exogenous opioid from coming and binding to mu receptors, right? It prevents exogenous opioid euphoria completely. The level of inhibition that antagonists like naltrexone will have on mu opioid receptors cannot be overcome by the usual opioids that are available on street, like morphine, like heroin, and even buprenorphine. Those who are working with opioid dependent patients, there are a lot of patients who take buprenorphine also. So even buprenorphine cannot completely overcome the antagonism of naltrexone. And anybody's out there sitting and thinking whether methadone can, no, it cannot. Buprenorphine has the highest affinity for mu opioid receptor from the drugs available, more than methadone. And if buprenorphine cannot overcome the inhibition of antagonist in naltrexone, methadone cannot. But when we talk about opioid use disorder, many issues come up when talking about naltrexone. Although it is an approved treatment, but when we compare it to other established treatments like buprenorphine and or methadone, there are some issues such that the retention, when we talk about opioid use disorder, we talk about retention of patients. Retention with naltrexone is lesser than with buprenorphine or methadone. That needs to be kept in mind. But because of the logistic issues with both buprenorphine and methadone and the issues due to the NDPS Act, buprenorphine may not be available, it may not be logistically feasible to give. So in such cases, naltrexone is a very good drug to use. Although there are multiple studies which will show that there is a lot of dropout, there are issues, but if there is an option to give, naltrexone is a very good drug which can be given in such cases also, and it is approved treatment. And also, just to mention in brief, long-acting injection of naltrexone, it is shown to improve the compliance, specifically in alcohol use disorder. But we do not talk much about it because it is not very easily or cheaply available in India. So logistically, it is not possible for us to use it. While talking about substance use disorder, it would not be right for me to not mention other substances. So what about nicotine? So it has been tried for weight gain, which happens when somebody stops smoking, somebody stops using nicotine, and it is shown to reduce post-cessation weight gain through various things, and it can be considered, although we don't directly give it's seen that patients who are using maybe alcohol or opioids and have nicotine dependence or tobacco dependence, in them when we give naltrexone, this is the effect that has been seen. Interestingly, when in cannabis also, there is mixed evidence. Sometimes clinically also I have seen patients respond very well to naltrexone, which was tried. Sometimes they report no effect whatsoever and maybe report worsening. So naltrexone has been tried in both these substances. And more importantly and more interestingly, naltrexone in stimulant use disorder. When you're treating a case of stimulant use disorder like methamphetamine, like cocaine, there are very less drugs which we can use. And naltrexone plus bupropion becomes a combination with good evidence. And a number needed to treat of 9. And it is one of the better outcome drugs if it can be given as a combination. That can be thought of even in stimulant use disorder. Moving on from substance addiction to behavior addiction, which are now, I think, the talk of the town, and number of cases of behavior addiction are increasing much more. So, in cases of behavior addiction, let's talk about gambling. Gambling use disorder and gaming disorder have now been recognized by the ICD-11. So, when naltrexone is tried, it has shown to reduce gambling urges and pathological thoughts. Dose rep is different in different trials, 50 to 150 mg. I have tried around 100 mg in more than 20-30 patients with good response. In cases of behavior addiction, we do not have a lot of options, and pharmacologically, the highest evidence for a drug is for naltrexone. It is not approved currently, but the highest evidence is for naltrexone in both gambling disorder and gaming disorder and other various behavior disorders also. Now, earlier when we talked about behavior addictions, we used to consider them as impulse control disorder. And if you see ICD-10, that is how they were classified also. But now impulse disorders have been separated from behavior addictions. But in cases of kleptomania also, naltrexone has been tried and has shown good evidence. Interestingly, borderline personality disorder, it is one of the most challenging diagnoses to treat clinically. And as psychiatrists, most of you would have worked with patients with borderline personality and would have felt how difficult it is for us as psychiatrists, as doctors to treat. And naltrexone is something which shows good response in reducing the impulsivity and, more importantly, reducing the deliberate self-harm. There are multiple theories, but one of the theories is that in borderline personality, self-harm is done because endogenous opioids are released, which reduce the pain and so on. So naltrexone tends to reduce a positive reinforcement that would come from self-harm. And hence, it is used and it shows good response. Similarly, self-harm behaviors in other diagnoses like autism spectrum disorder also it has shown response. And interestingly, in eating disorders also, in a combination with bupropion, it is being tried. Fixed dose combination of naltrexone and bupropion shows very good response in eating disorders. And perhaps this is a diagnosis which we are seeing less. We were seeing less maybe 3-4 years ago. Number of cases that are presenting now are more, and maybe 5-6 years down the line, we'll see far more cases of eating disorder in our country also. It has also been tried in dissociative disorders. Dissociation is also something in which everything is tried, from antidepressants to antipsychotics. Some things work, some things not. There is some evidence for naltrexone. While I would not say this is the first line or should be tried, but it has shown some response. And in cases when nothing is working, no amount of psychoeducation, no amount of therapy, no amount of cutting the gain is working, maybe think of this. Very interestingly, till now, I was talking about naltrexone at a higher dose. And by that, I meant 50 mg to 150 mg. What about very low dose of naltrexone? As low as 1 to 4.5 mg. And let me tell you, this is not available clinically. So you cannot go and try. These are from the various evidence that are present, where they actually have 1 mg, 4.5 mg. So it has shown to reduce chronic inflammation, this and that, through various mechanisms. And hence it becomes important in maybe fibromyalgia and chronic pain also. What we need to know a bit about precision psychiatry is the pharmacogenomics. Maybe that there will come a time when we'll be able to personalize the treatment a lot based on the genetics of the patient. So In cases of naltrexone, we talk about OPRM1 genetic polymorphism, and this decides how well naltrexone can bind to new receptors and can be a long-term thing to test as a biomarker to see the response in precision psychiatry, although clinically we don't do this. Most importantly, when we have talked about any drug, we have to talk about it in pregnancy and lactation. In pregnancy, various guidelines mention that it should be avoided. We should avoid using naltrexone if active opioids are present. There is always a risk of acute febrile withdrawal also, and it is always better to use an opioid agonist therapy like buprenorphine, like methadone, as compared to naltrexone during pregnancy. Although there is some evidence that does not cause a lot of harm, and with the logistic issues of buprenorphine, I have also seen some cases during my DM in which we actually decided to give naltrexone during pregnancy itself due to the various issues that were there and along with patient consent. And eventually there were no fetal harms at birth. And similarly, it's the level that comes in breast milk will also very low, but it is considered safe to use. In summary, when we talk about naltrexone in disorders where it is not currently approved, just to talk about the level of evidence, it has high level of evidence in binge eating at 50 to 150 mg. In gambling, it is moderate to high. And in behavior addictions like gambling, this is the drug with the highest level of evidence. Most trials support this. It is not approved. It might get approved in times to come, I don't know, but currently not approved. And similarly, in autism and dissociation, also the evidence is either low or moderate. It's more of a theoretical thing for us to know. Just to talk about the comparative psychopharmacology of drugs, which are similarly used by us in addiction psychiatry. Other than naltrexone, we talk about acamprosate, disulfiram, and baclofen. All these drugs are used, and the top three drugs are approved for alcohol use disorder, but they have very different mechanism of action. And naltrexone acts by blocking the mu opioid receptors. Hence, it reduces the active craving, it reduces the binge drinking, it reduces the impulsivity, right? It reduces the heavy drinking days, most importantly. And as harm reduction strategy, in alcohol use disorder, we can think about naltrexone. And it is not a harm reduction strategy in opioid use disorder. Buprenorphine or methadone are the only harm reduction in as approved in opioid use disorder. So rather than thinking just about receptors, we can think about maybe a reward deficiency syndrome spectrum in which substance addiction, behavior addiction, eating disorder, and self-harm come. Thereby, we can think about circuits and think about using these drugs. Further directions are we can think about integrating neuromodulation, which also tends to target circuits rather than drugs. And we can move towards more precise treatments in psychiatry. Right. So to end it, we have to think about naltrexone beyond addiction. And in psychiatry, we have to think more about circuit. So mechanism-based shift should happen in psychiatry also. We have to treat the circuit, not just the symptom. Thank you. Now I'll be asking my respective panelists to give their expert opinions on this. I'll start with Dr. Pratik.
Okay. Uh, Congratulations for the excellent presentation, Dr. Sidharth. I would like to add some points as what I have read regarding the use of naltrexone in broadly defined behavioral addictions. As you said, 50 mg per day dose is not sufficient for these illnesses, and we need to give 100 to 150 mg of naltrexone per day. Some have said that at 50 mg per day, the naltrexone doesn't blocks delta receptors sufficiently, but at higher doses like 150 mg per day, delta receptors are also blocked sufficiently. So we see the improvement in broadly defined behavioral addictions due to this mechanism. Also, low dose naltrexone at 50 mg per day has a can increase pain due to suppressing the opioids, but low dose naltrexone can have paradoxical anti-inflammatory analgesic properties. So it is also used in Crohn's disease, rheumatoid arthritis, multiple sclerosis, complex regional pain syndrome, also long COVID symptoms. But the level of evidence is not sufficient till now, and also we do not have available formulation at these low doses. And currently, we have only it available at only 50 mg per day. Also, as you said, OPRM1 polymorphism, the prevalence of G allele carriers is 50 to 60% in Asian populations. So this is quite significant, and I hope in future we have pharmacogenomic testing available in our state and the peripheral centers also. So with this, I would like to end my input in this presentation.
Thanks a lot, Dr. Pratik. What you are saying is like, right, behavioral addictions, we have to treat higher doses because it's a mu receptor antagonist very strongly, but other receptors, it's not a very strong antagonist. So as you are saying, with respect to delta receptor and the receptors, and yeah, in other things like you mentioned, I was not aware about choosing Crohn's disease. Thanks for adding that. Thanks a lot. And
Thank you, Dr. Sidharth.
if I can ask Dr. Shubhangi, ma'am, can you please?
Hi, yes. So a beautiful presentation, Siddharth, and you have explained how quickly naltrexone has moved from the niche addiction to a surprisingly, versatile tool in psychiatry. But what I would like to add here is when using in ASD, it will not target all the core symptoms of autistic. It will not target the core autistic symptoms, but only the symptoms associated with self-injury or impulsivity. And also when we are thinking of giving it, we should it should always the patient should have significant self-injurious behavior or impulsivity for us to even think of starting it, as well as when compared to the traditional drugs that we use like risperidone or aripiprazole, still the data is limiting if we are using naltrexone, I guess. Also, I have used this drug, naltrexone, along with bupropion for obesity in a lot of patients. I think around 15 to 20 patients till now. And in most of them, I have seen some responses, while many of them have reported a lot of side effects. So, what is your take on that?
Ma'am, I have also used it not directly for obesity, but many patients who present for something like alcohol use disorder have abdominal obesity and obesity also, and also comorbid nicotine use disorder. So as a combination, I have tried. So patients do report reduction in weight that happens that I've seen. With respect to side effects, I would not say I've seen very prominently, but the number of patients I would say with particular obesity for me are limited. So
Okay, so 3 of my patients, they abruptly stopped it when I used it in combination with bupropion for obesity. So I have my reservations in that regard. That's why I wanted to ask you.
so you're saying the main diagnosis was obesity and no other substance or
No,
no
no,
other.
no, no, no. Other, it was antipsychotic induced obesity or other drugs induced by other drugs. That's why I started it, not just obesity.
So what about a psychiatrist treating obesity as a primary diagnosis? Maybe semaglutide is being used by endocrinologists and respective doctors. What
It
about us?
has been proven to be better than GLP-1 analogs that we are using. I think so. I'll have to read again. But that is the data that has been coming along for it in case of use with bupropion and naltrexone.
That's a very valuable point, ma'am. So as psychiatrists, you can also focus more on obesity also.
Mostly for patients who are on our drugs and end up, having a metabolic side effect or being obese. those are the indications where I have used it.
So
So
in
maybe
cases
future
where,
inputs.
yeah, maybe in cases where our drugs are causing obesity, we are treating it, but you're right now. Thanks for adding this thing.
Thank you so much.
Dr. Charvi, if you can unmute and add your perspectives.
Uh, Thank you for the presentation, sir. I learned many new things that I was not aware of previously. So I have used it at IBHAS only, and in the limited use that I have with naltrexone. Earlier, my approach was initially when I was a JR that strict abstinence should be the focus of de-addiction per se. But then when I used it, when I use naltrexone, I realized that many patients are not ready for that kind of commitment, a commitment towards complete abstinence. So in that way, naltrexone is a very good option, especially when the patient has intense craving or impulsivity. And I have also used low dose, micro dosing, like you mentioned, 1.5 mg and 3 mg in chronic fatigue syndrome. Yes. So that is available on some online pharmacies. The patient was already on duloxetine as well. So I don't know. The patient did show slight improvement, but I'm not pretty sure whether it was because of duloxetine or naltrexone. So I will follow up the patient more so to see.
Thanks a lot. Now, that's a very interesting perspective that I was not aware that we are having 1.5 to such lower doses and we can try them. That's a very interesting perspective that you provided. And second point that you said that in cases of alcohol use disorder, complete abstinence might not be the goal, and patients won't want to still drink socially or for any other reason. So we can think of naltrexone. That is something which we do very, very frequently. Sir, Dr. Sidharth, sir, if you can add your perspective, sir.
Yes, Dr. Sidharth. Uh, Very crisp presentation. I work with the patients, in a setting which is primarily for the substance use disorders. And we've used naltrexone extensively over past 7, 8 years, because of the fact that we do have this in supply. So over this period, I found it to be a very wonderful drug. And just you've highlighted different indications with various level of evidence. So if there are a few things I would like to highlight is that one point is that the issue with naltrexone causing hepatitis is really overblown. You've mentioned that black box warning has been taken off in 2013. So over a period of last 7, 8 years, when I've used extensively, this just been one case of naltrexone induced hepatitis that we've encountered. So I found to be relatively safer drug in terms of patients who've been drinking and with terms of hepatitis. The other point that you made, in India, we don't have a lot of stimulant use disorders, but in certain pockets, and you've been in NDTC Ames, so you would have observed there is a special kind of stimulant that people tend to use, methamphetamine. So we've had, almost 50, 60 cases of those that we've seen over past 50, 5, 6 years. And I've used the combination of naltrexone and bupropion to somewhat successful degree. It worked well for patients who were just using methamphetamine, but in patients who had comorbid substance use disorder, the results were not so nice. But for methamphetamine, the combination really worked well. If I could highlight. And the other one is, I think, the what we've not discussed, but again, evidence from certain case series is naltrexone use in porn addiction. There
Yeah,
are case
maybe.
reports, where use of naltrexone with CBT or psychosocial intervention have some effect. We had reviewed for Turkish Journal of Addictions 2 years back. So although there are no, outright RCTs or something like that, but there is evidence that it does lead to, reduction in porn addiction or those desires, because the original studies are from the prisoners, in early in 80s, 90s, who were very aggressive and who were sexually very violent, and they'd given them naltrexone, and there is evidence that such impulses reduced in those patients. So in that category also, there is some amount of evidence, although there are no RCTs. Yeah, that's my part.
Thanks for adding, sir. You have added very important perspective about stimulant use, because we know about, we talk more about alcohol, opioids, but in stimulant use disorder, where the number of options are very limited for us to use, naltrexone is in. And similarly, in case of behavior addiction, porn addiction, you're saying, and even who had compulsive sexual behaviors, thank particular term you're saying, and with your experience, sir, what would you say? Like, what is the timing? Because there's a lot of evidence when to start with respect to alcohol use disorder. So what has your experience been?
Yeah, so clinically, I have found it to be a very flexible drug. There has been a lot of patients who've just come to us, and we started with the detoxification phase also. And there've been patients whom we've given kind of a week or 10 days, and they've followed up. So I've really not found a lot of difference in terms of difficulties in starting naltrexone. It would be difficult for me to comment whether just starting at the onset helps or you wait. But the flexibility with the fact that once patient comes and you may not be sure whether they'll come or not. So at least you can, take the liberty ensuring that, investigations are ordered, and you can start with relative, safety profile.
So I totally agree. Like many times in OPDs, we are not sure whether the patient will come back or not. So, and we feel clinically liver function is normal. Roughly what we used to see is the patient does not have jaundice or icterus, which would indicate maybe more decompensated or worse liver functioning. So we used to start, like even in acute withdrawal management, we are not sure if patient is going to come back in alcohol use disorder, I'm saying. So start with tapering dosage of respective benzodiazepine along with naltrexone. Clinically, if we feel that liver function is okay, and get the liver function done, and whenever the report comes and patient does come, we can adjust. Thank you, sir. Thanks for adding very important perspectives about this. Thank you, sir. Dr. Udit, if you can please give your comments and add the discussion.
Hello, Dr. Sidharth. Thank you for a very crisp presentation. I'd like to add three things here. First is the NNT of naltrexone, as you said, is 11. That is for heavy drinking, a reduction in heavy drinking. For complete abstinence, it is probably 18. So that the number might dissuade a lot of us to use naltrexone per se. But naltrexone is polymorphic. Combined with disulfiram, which is a deterrent agent. It can be combined with a host of other anticholinergic agents like acamprosate or baclofen or topiramate. That way it becomes very successful. So the data for Indian patients with alcohol use disorder is not really available much. So that NNT shouldn't dissuade anybody from using naltrexone in alcohol use disorder. The second and third point would be based on the two RCTs that I'm currently involved in. The first one would be using the fixed dose combination of bupropion and naltrexone or Contraf for weight loss. We are doing an RCT, a placebo-controlled RCT on psychotropic induced weight gain. Quite interestingly, apart from alcohol and opioid use disorder, the third approved condition, FDA approved condition of naltrexone would be weight loss. The issue there is a very fascinating story to the origin of this drug. Prior to this combination of naltrexone with bupropion, whatever medications we had for weight loss, the mean weight reduction was about 5%, and that is the threshold that is required for a drug to be approved as a weight loss medicine. So we had topiramate, we had the orlistat and all. They're not very effective, even metformin for that matter of fact. This is the only drug that actually crossed the 10% threshold. So by the end of the therapy, which is like 8 weeks, there was a baseline reduction by 10% from the baseline weight. So that is why the premise of the drug was very fascinating. But as one of my co-panelists informed, the tolerability seems to be very poor. The recommended dose is 4 tablets per day, and most of the patients they drop out when you reach 2 tablets. So that has been a bottleneck. Unfortunately, the fame of the drug didn't last. It was approved in 2014, but in 2017, semaglutide came up to the market, which breached the 15% mark. And then the tirzepatide, the Mounjaro drug came in 2019 or 20, I believe, that crossed the 20% mark. So now, considering the weight loss medicines from an endocrinologist perspective, bupropion naltrexone stands at a back point. But for us, maybe we should give that drug a fair trial on where it can be put in. When people with impulsive eating disorders with weight gain, they might still benefit. So that is one point. The second study that I'm currently involved in is more fascinating. It's about low dose naltrexone. As you rightly pointed out, we do not have access to low dose naltrexone. So what we're doing is we found our hands on a dispersible naltrexone formulation. So we are making it 100 ml of mixing it 100 ml of water and allowing the patient to take 10 ml of it. That is how we're giving it. As you mentioned, it acts in 2 channels. One is that it essentially enhances the opioid release. So being an opioid blocker, it temporarily blocks the opioid receptor. So essentially enhances opioid release and is also an anti-inflammatory agent. And it has been used as an anti-inflammatory drug in fibromyalgia, in rheumatoid arthritis, in Crohn's disease. So we are now looking at it, whether it is able to lift anhedonia in patients with depressive disorder who have resistant anhedonia. There has been 1 or 2 trials. We are doing it on bipolar depression patients. So low dose naltrexone as an augmenter for lifting anhedonia. So that is what we are currently working on. The result remains to be seen, but I'm very, very fascinated by the premise with which low dose naltrexone can actually act on. There can be so many indications where it can be used. So that would be the inputs from my side. Thanks again for your presentation.
Thanks, sir, Dr. This. What you mentioned is actually very important points. Okay, if we think about weight gain from antipsychotics, antidepressant, that is there, but a whole entirety of what you are saying, binge eating disorders, which are perhaps very difficult to treat, and a combination of naltrexone and bupropion can help in them all binge eating disorder per se, reducing the impulsivity and reduce the weight gain also in them.
We should also keep in mind that these patients will normally report to an endocrinologist or the physician rather than coming to a psychiatrist. So that is something that we should keep in mind.
Yes, sir, that I definitely understand. Most of the patients, even with quote psychiatric disorders, do come to neurologists and respective doctors. That is always the limitation. But what you're saying is very interesting, that a drug like naltrexone, which is an antagonist, used at 50-100 mg, blocking words, but at a lower dose, it's behaving very differently with whole set of different indications, fibromyalgia, rheumatoid arthritis, Crohn's disease, which are very interesting. Like it's becomes a whole different thing at lower doses,
Right.
which you are saying is very important for us to think and something more maybe to explore, and that adds maybe more to our own armamentarium as psychiatrists. The kind of things that we see, we treat. I understand that everybody will go to a respective endocrinologist, neurologist, and so on. That's fine. But we now, with what you are saying, we can treat so many different things. And naltrexone drug like and such must say such an innovative thing that you're saying, using naltrexone or dispersible to make the lower dose, and that is a typical like jugaad that we Indians.
That's an
like.
Indian jugaad that we
Yes.
did. Yes.
That is amazing, sir. Thanks for having such an important perspective. Thanks a lot. Then I would ask Dr. Parth to please give your perspectives.
Yes, sorry for joining late, and congratulations, Dr. Sidharth, for a very nice and very illustrative presentation. I would just share my experiences where I have used naltrexone and got good results. So I worked in a de-addiction center for 8 years now, and I have found very good results in patients with chemsex type of profile, homosexual patients using meth and then engaging in sexual activity, and 2 cases where I think 100 mg was the dose, and that gave very good results. Means post discharge follow-ups and all, they were loyal to a partner, not engaging in drug use, before sexual activity for at least 6 months that I followed up. So that was a good thing that naltrexone worked very well. And I found, okay, this is another area. So because we were using in behavioral addiction also, so we tried this and that worked. But the dose was, as I said, at 50 mg was not that enough. Then multiple substance use, again naltrexone, good dose 100 along with endoxifen, so that give a good result in 2-3 cases. That's what I got to know. Means there are not trials done that combination is working well or not, but we tried, and in 2 or 3 cases we got very good results in those cases. And as mentioned very good with one of the panelists only, that naltrexone with disulfiram, whose motivations are good, there we have got very good results. So many patients who were sober, they were on this combination to maintain sobriety, and that was very helpful according to my observations, where I have used naltrexone and got very good results. Only challenge I have got is those who are not tolerating it. First dose itself, nausea, vomiting, severe, and they feel that this was horrible. I don't want to take this medicine ever. Few reactions we have got that also. Even half dose, 25, we tried to give, but that also did not suit. So if pharmacogenomics is getting there where we can identify and give, that would be the best thing that I can give my points on this.
Dr. Paz, you mentioned very interesting point, and one thing about chemsex, you are saying that whenever we talk about stimulant use, the first thing that comes to mind is always chemsex.
Yeah.
And it becomes very, kind of a high risk behavior and
Yeah.
kind of difficult to treat. So naltrexone, as you're saying, very interestingly, and what you're saying makes a lot of sense. So we all thanks a lot. We have also some questions, so I'll answer a few them, and I'll also ask the panelists to share their experience. First of all, the first question is, what is the evidence of opioid overdose in persons on naltrexone? So as long as a patient is taking naltrexone, their mu receptors are blocked. But interestingly, patients, when they stop taking naltrexone due to regular inhibition of mu opioid receptors, the risk of overdose increases, right? Because patients would maybe try to use the same amount of opioids, and even the amount of opioids they were previously using would give them more effect because of the upregulation of receptors. And there is evidence that there is higher level, very high risk of overdose and death when antagonists like naltrexone are acutely stopped and patients try again. So that is something which we always have to keep in mind. So as a part of our psychoeducation for opioid use, when I was doing my DM, so we used to tell these patients these things clearly, that right now they might be taking on tolerating 1 gram, 2 gram, or so on for smack. When they take naltrexone regularly, their tolerance will come down. So do not, ideally do not use it again, but that never works actually in the world. For harm reduction, we used to tell them that the reality that this will happen, we tried our best because there is always a very high risk of overdose. And as clinicians, when we are treating opioid use disorder or any substance, remember it's a relapsing and remitting pay. It will happen. Relapse is the rule rather than the exception. Always address this point. So this is a very good question. What anti-craving medications can be combined? So we can combine naltrexone and acamprosate, and what Dr. Pathol has also said, disulfiram and acamprosate. So disulfiram and naltrexone we can combine. Very good complete sobriety, very good response. Then this question, one more I want to say. Buprenorphine and naltrexone, the effect is that naltrexone will block the mu receptors, so buprenorphine cannot overcome this blockade as such. So it will mostly nothing will happen, right? And with respect to borderline personality, it does reduce the impulsivity, it does reduce the self-harm. And these are the questions. If any of my panelists want to add more perspective to these, any of these questions, add more points. Any of you please want to add, Dr. Pradeep, Dr. Sidharth, Dr. Uday, Dr. Charbi, Dr. Shubhangi, anybody wants to add more for the questions that our respective audience has asked?
Can I take this?
Please go ahead, please.
So there is the use of naltrexone in anything that is rewarding has been well established. So for example, it will modulate the reward circuitry and make the behavior less pleasurable. For people with borderline personality disorder, they cut their wrist or do any form of self-harm, deliberate self-harm, and there is a rush of endorphins and they feel relieved. Naltrexone is going to cut that feedback. So eventually we expect an extinction of that behavior to occur. So that is the theoretical basis of using naltrexone in borderline personality disorder. Sadly, there has not been very strong randomized blinded trials to establish this as a recommended form of treatment. So yes, case specific definitely we can use, and also we know for a fact that there is an impact of naltrexone on impulsivity. So people who have borderline personality disorder, they tend to have higher impulsivity in their temperament. So that is something that can help. Theoretically, it can help, but no treatment guideline as of now recommended because of lack of evidence. I want to add on one very interesting thing over here. So in borderline personality disorder and self-harm, it's a reward breaking pathway for people with autism and self-harm. There, it is hypothesized that those children or adults with autism, they have an opioidnergic excess. So endogenous opioids are circulating more. That reduces their pain threshold. That is why they end up doing self-harm. So if you give naltrexone on a higher dosage, the endogenous opioid tone is going to come down, their pain sensitivity is going to normalize, and they will start feeling the pain and eventually refrain from self-harming behavior. So these are two very different kind of approaches to manage self-harm in two different clinical population. Theoretical basis definitely exists, but I think we should, as clinicians, we should be cautious and use our own judgment, clinical judgment in taking a call in individual patients. So that should be the response from my side for this.
So that, I think, Dr. Pratik, do you want to add something?
Yeah, someone asked about a combined use of buprenorphine and naltrexone. That's the exact reason the buprenorphine, which is available in the market, is combined with naloxone. So that if diversion happens, if someone uses it IV, naloxone will be activated and it will block the effect of buprenorphine. That's the exact reason why we do not combine both of this, buprenorphine and naltrexone. So this is my answer for that question. Thank you.
Add something over here. So
Please.
to simplify this, if somebody is taking buprenorphine, they should not be given naltrexone because that is going to precipitate withdrawal. Naltrexone is a higher opioid blocker as compared to buprenorphine.
Yeah.
If somebody is taking naltrexone and they take buprenorphine on top of it, it ideally should not act because the opioid receptors are occupied. So there are two different scenarios. Both of them should be kept in mind.
And just to add one more point, so somebody whoever asked this question about naltrexone and buprenorphine, there are trials for stimulant use disorder from some European country, I don't know, Sweden or Finland, in which they tried as a method of, in which they tried the logic behind in stimulant use disorder combination of naltrexone and buprenorphine. The logic behind that was to block other receptors and not to make patients of stimulant use disorder dependent on buprenorphine and not to cause opioid use disorder iatrogenically. There was a very small trial a long time back. So if somebody is asking that, that is the thing. But clinically, we have never seen that. There's just one or two trials from Sweden or Finland. That is the question specifically being asked. And tobacco dependence, very common. Naltrexone per se will not act tobacco. We see some benefits with respect to the weight gain that happens when you have to treat it separately. Varenicline or any other bupropion, varenicline or any other appropriate NRT has to be added. Like if you're trying to treat tobacco use or nicotine use disorder, because naltrexone is not going to help much there. I have personally seen a lot of varying things. Some people report that after taking naltrexone, they did not feel like smoking, or there's some other issues, or some reported they wanted to smoke. But per se, directly, you cannot rely just on naltrexone for smoking cessation. If there are any more questions or any of my respective panelists, if you can see in internet addiction again, internet addiction or any other behavior addiction, when you go and see trials, everything has been tried. There's no approved drug. Naltrexone is perhaps a drug with more evidence. It is tried along with multiple behavior therapies to respond. And if somebody can, naltrexone magrim, I don't know what that is. And if that's a trade name, I'm not very sure. Somebody
Magrium
invented
is a magnesium supplement, I believe.
it. I have no idea. Magnesium salts. If somebody can
I
comment
don't
upon this particular question, please.
I don't think there are in direct contraindications per se. If, the sometimes whatever magnesium salt you're using, the gastric tolerability profile might be affected. So, and naltrexone is known to have a poor gastric tolerability profile, at least during the initiation phase of the treatment. So that interaction might be clinically significant. But as otherwise, I don't see any direct interactions between these two molecules.
So for continuity of the unit, we'll note down this question. We'll see if there is any particular evidence, because as he's also saying, I'm also saying I don't recall any where it being mentioned about particular interaction. We'll definitely do. Buprenorphine transdermal patch in alcohol, like that should not be tried. Don't give buprenorphine for alcohol use disorder. That should not be tried at all, neither theoretically or practically. So please don't think of treating alcohol with buprenorphine patch.
Unless, of course, you are dealing with comorbidity. Or you want to
like pain.
or you want to shift him from alcohol dependence to opioid dependence.
Maybe it's easier. Practically speaking, it is easier to treat opioid use disorder because buprenorphine is very effective as opposed to the treatments we have for alcohol use disorder. So maybe that's a very
It's
different kind
easier
of a
to get
strategy.
it's easier to get addicted to the opioid as well. So that's something we should keep in mind.
Maybe the idea is that we cause the addiction, we treat the addiction. Maybe that is the idea.
This year during I also have done my residency from AIMS Delhi and was posted in NDTC for a good 1.5 year. So during that posting, as it must be happening now also, there are people who sell adnog outside. A lot many ADS cases would come up and they buy buprenorphine from outside by giving 100 rupees per pill and they end up getting dependent on adnog. So that is something that has happened. This person reminded me of that.
Right, so all these patients used to try all permutation combination while the wards stay and even outside also. Like the treatment patients use on themselves and others is far beyond what we can discuss or think. Like, I have personally seen patients giving each other their buprenorphine, disulfiram while they're in ward sharing medications. Like, no, maybe the logic is sabka saath sabka vikas. So that patients try everything. We can't. If there are no more questions.
Dr.
Sure.
Siddharth, I would like to ask one more question. I want to ask your experience regarding pharmacogenetic testing for that single nucleotide polymorphism for OPRM1 gene. Is it available in Delhi? It is not available in Chhattisgarh, so I am not aware if it is available in India.
It was being done as a part of some ICMR project. I think there are evidence and papers also. I think alcohol use disorder has been tried. I think there are papers. Per se, we are not using it clinically. The cost is too much, but it was used in some project, ICMR project.
Thank you, Dr. Siddharth.
Thank you.
Can I ask a question myself?
Sure.
Any of the panel members have you used naltrexone's that IM or transdermal implant preparation? And if yes, then is that good experience with that?
So one case I have given that implant for alcohol addiction case, but again it was for 3 months only the patient stayed. After discharge, around 2 or 3 months, relapse had happened. So not very much successful that I could find. So, but the company claims that they are better, the outcomes are better and all. But
Yeah.
Much.
I think the cost
There
is
has
a
been
huge
a
limiting factor.
there has been a recent surge in marketing of that preparation. That's why my interest rose so that.
Yeah.
I think we need to try. Like currently, the cost is a huge limiting factor, but in case like alcohol use disorder, we can think about long-acting, like if you think about long-acting injections in other aspects like schizophrenia, other diagnosis, even in substance use, we can try, we should try, but right now, given the logistics, it does not become practical for us in India.
Sir, I would like to add, we have given Vivitrol, long-acting injections of naltrexone. From US, we had got in our rehab. So that got good results. Means in 3 or 4 cases we have.
Yeah.
Okay.
I think even the evidence aligns with that IM injections have
Yeah.
good response as opposed to implants.
Implant. Yeah. And they were asking, other patients were also asking, but we did not get more than 3 or 4. We had to say it was just for a month, and we got samples, so we tried. So it was little difficult.
So if there are no further questions, we can end it.
Yeah, so I'll just give the vote of thanks. Thank you very much, Dr. Sidharth, for your very lucid and exhaustive presentation, right from substance to behavioral addictions. And your wonderful presentation has garnered about 320 viewers online, which is really a grand success. So thank you very much, sir, for your very well presented presentation on this topic. I also wish to thank all the panel members, Dr. Charvi, Dr. Pratik, Dr. Subhangi, Dr. Udit, Dr. Sidharth, as well as Dr. Parth Soni, for giving us all your valued clinical experience, which is very, very important and has helped in enriching this topic and enriching all the viewers, experiences also. So thank you for augmenting the experiences with your rich experience, clinical experience, and I'm sure that everybody has benefited a lot by today's discussion on naltrexone. Thank you very much, Dr. Sidharth. Thank you very much, all the panelists, for making this a very, very meaningful and learning experience for all. Thank you, and good night to
Just
all.
one
Thank
point
you.
to add, for everybody who has joined, thanks a lot. Any questions that we did not answer or could not answer, we'll get back to you. Please write it. We'll be coming back to talk about acamprosate very soon. So anything which was not answered or you could not ask or whatever, you please write that. We'll discuss that next time onwards. So next time we'll be talking about acamprosate, and whatever discussion remains from this time, we'll carry on that. Thank you, and thanks all my panelists. Thank you.
Thank you very much. Thank you all to all of you. Thank you. Good night. Good night.
Thank you. Good night.